Hi, everyone. I am so excited to be joined by Dr. Mariano Palena from Italy. And he is restoring, I think, about what?
Between 700 and 800 patients per year.
And so I'm really excited for you to share with us today one of your most recent cases that some might have thought was not possible.
It was a relatively young patient, 79 years old, that is young compared to the patients that we actually every day treat between 80 and 90 years old. That arrived to my care because he manifested a recurrent critical limb ischemia. He was a patient that I treated 4 months ago, and for a kissing ulcer between the second and the third toe, and I was able to revascularize all the below the knee segment, but the patient had a good way after this first treatment, and again after 3 or 4 months he was with a very low TCPR2, so transcutaneous oxygen tension was down again. This is the first sign of CLI, and his ulcer were not able to completely heal. So the patient was under the table again, and what I did was a CR2 angio. I invite everyone to think about, because this is
instead of using contrast fluid, because some people have renal issues, some people have an allergic reaction. But this is really important that people understand that even if they do have a sensitivity to contrast fluid, to find a doctor that uses CO2. But even some doctors, Dr. Palena, here in the States, they're very hesitant to perform cases below the knee because they don't find that CO2 is adequate enough for them to see effectively down into the below the knee vessels. But obviously I'm looking at your fluoroscopy images here and it seems pretty clear to me. What are you doing that's different?
Well, honestly speaking, I think I'm doing nothing real different than the other ones. It's time and job related. I started to use CR2 5 years ago in partnership with an Italian company. The name is AngioDroid. And what they did was an automatic injector of gas, of CO2, and I was pretty well involved with them in the develop of this machine and developing this technology, and with Philips also supporting them to obtain a good algorithm for DSA, for the digital subtraction angiography. So finally, what I have today is a good machine to inject CO2, good parameters that can be adapted to CLI patients, low pressure and low volume, in the way the patient doesn't feel pain and doesn't move. And this is the most important thing, because movement is the first issue, the first problem when we want to obtain an adequate and high quality images. So low volume, low pressure, and good machine that inject at a controlled pressure and volume, and good software for reconstruction. So nothing different, just go ahead with technologies and developing new strategies. But yes, as you said, Kim, it's very important to consider the CR2 option in patients with renal problems, or in patients borderline, that we want to avoid any renal issue in the future. So we can today obtain very nice images above and below the knee, and also below the ankle with CR2.
And let's talk about what we see on the screen right now. This is a below the knee vessel. You have the knee up here. And so talk about as we're coming down, we have the anterior tibial.
Well, this is a below the knee. It's a lateral view of below the knee. So from the left side, you can see a posterior tibial, diseased posterior tibial artery. In the center line, there is no peroneal artery, but should be there. And in the right side, what we can see is the ostium of anterior tibial, with a very long occlusion of all the anterior tibial artery.
right? You can see it's pretty heavily calcified.
Yeah, all the vessels were pretty calcified. It's quite normal in the CLI patients. It's quite normal. So this is the typical diabetic foot CLI patient.
And then you go on into the foot, and that is really there's almost no flow down there.
Well, in the foot, as you mentioned, and as we are arriving in the video, and the lateral view of the foot, we're able to identify some collaterals in the plantar side with no flow in the dorsal circulation and very thin lateral plantar artery, that is the artery that feeds the forefoot. And the only relatively healthy artery in the foot is the median plantar artery, that is a secondary vessel. The second view, the view that you are showing now, is an anteroposterior view again that shows us that there is almost no blood flow for the toes because there is a blockage, an occlusion in the plantar arch. The arch is a small segment of artery from where every metatarsal artery born, so give origin for all the blood vessels for the toes. So there is no arch, anterior tibial is occluded, dorsalis pedis is occluded, there are multiple stenosis in posterior tibial and stenosis or subocclusion in the lateral plantar. So it's a very complex situation below the knee, below the ankle.
So at this point, you've seen the fluoroscopy images, you've seen all the way into the foot using the CO2 versus the contrast fluid. What is going through your mind right now in terms of determining options to treat this patient?
Well, it's important to have more than one option, because otherwise, if you consider only the plan A, if you fail, the procedure is a failure. So in that cases, my considerations were antegrade recanalization of anterior tibial and dorsalis pedis, and if it failed, the second option was considered to perform a recanalization of posterior tibial, plantar artery, and pedal-plantar loop technique, and the third option was to retrograde access in somewhere.
So this is during the procedure. Talk about what you're doing here.
I start the procedure with a full French catheter. This is a Berenstein type 2 catheter and an 018 gate wire. This is a Terumo Advantage 018 gate wire that allowed me to engage the anterior tibial. And this day, Terumo offered me the chance to be the first around the world to test the NaviCross 018 Support Catheter. So, as you can see in my hands in the video, I was preparing this NaviCross 018 Support Catheter to be able to enter in the anterior tibial with this small catheter. This catheter is an 018 platform. So through this 018 Terumo Advantage guide wire, I was able to engage the anterior tibial, and rotating using the drilling technique with this guide wire, I was able to engage the lumen of the anterior tibial and go down. With the guide wire and the support catheter. The crossing was not so difficult, but some plaques obliged the guide wire to go around. You can see that the guide wire was not going straight. There was a place in which the guide wire was not able to stay in the lumen and starting to go out of the lumen. So at that point, I obliged the guide wire to make this loop, and it allowed me to stay in the vessel, arrive to the foot. At that point, at the ankle level, I decided to remove the guide wire and inject a small dose of contrast. I think it was the only 3 cc's of iodium that I inject in all the procedure. And I was able to identify some landing zoom. The dorsalis pedis was visible at that point. It was for sure diseased artery.
And this is what's really incredible for people to see is that, look at that. I mean, you are clear into the foot and you are revascularizing the vessels there.
Yeah, yeah. What I was not able to identify from the beginning, so dorsalis pedis and the arch, I was able to cross and to engage it with my guide wire 018 and finally 014. So that allowed me to recanalize anterior tibia, dorsalis pedis, engage the arch, and finally be back from the arch, from the dorsal circulation into the plantar circulation, performing the pedal-plantar loop technique. I inflate a balloon. It was a conic balloon, 2.5 distally, 3 millimeters proximally. And this was the first result after balloon angioplasty of anterior tibial and dorsalis pedis. As you show in this control with CR2, there were what was occluded before was patent now. Still some recoiling point in the anterior tibial, so I decided to repeat the angioplasty and to use a 3 millimeters long balloon to treat all the anterior tibial. And the result after this second angioplasty was much better, with better flow, much better in terms of less recoiling and better washout of the vessel.
One of the things that we hear all the time from patients, and I had never heard it until just recently, and now I'm hearing it a lot, that people have too small of vessels to treat. Can you talk a little bit about that? Because I see you going in and I look at the size of the wires and the balloons and even some of the stents that we have out there today, and it's hard for me to believe that a doctor cannot treat these supposedly small vessels.
Vessels are small for itself, for sure. We are talking about between 2 and 3 millimeters in diameter and below the knee and below the ankle. So are not big vessels compared to femoral artery or to aorta, are small for itself. It's never mean that you cannot cross or you cannot treat or you cannot open these vessels. In fact, this is one of many cases, one of these 7.5 or 800 cases that I perform in a year. And in most of the cases, I achieve this type of result. So exists the possibility to obtain this type of result as you are showing now with direct blood flow for the foot. For sure, skills and devices are necessary to obtain this type of result.
This is beautiful. This is clear into the foot with literally wires, and you decided to use what's called a drug-coated balloon. And I know there was some debate here in the US over paclitaxel, but they have determined that if the doctor determines it's safe and it's right for a particular person, then it is the best option. And it can have a really nice result, especially for someone's vessels that have a tendency to reocclude.
Well, yeah, this was an option for this patient because, as I said before, from the beginning, the patient was on the table for the second time. And the reocclusion, it was an early reocclusion after 3 months. So what we need is something new, something better. So that drug-eluting balloon, drug-coated balloons are actually one of the tools that we have to fight behind restenosis. For sure, this case, this patient recurrence, critical limb ischemia recurrence was related to early reocclusion and probably to restenosis. So yes, I was evaluating. In fact, this case was a live case that I did from to Mexico. In fact, it was in Spanish. And we have been discussing about the option of DCB. And finally, we decided to open all the anterior and dorsalis pedis and also to dilate the posterior tibial, the stenosis of posterior tibial. And in this vessel, I decided to use a drug-coated balloon. The drug-coated balloon that I have actually available for tibial arteries is the Lutonix one from P.A.D. with very robust data after randomized clinical trials, even in US. So I decided to use it, yeah.
So what's overall the moral of the story here? It's fantastic. How long do you think that this particular procedure will actually last, or this result will last? What's your experience with a patient after performing a procedure such as this one?
Well, usually this, sorry?
What's the patency, long-term patency on this?
In fact, usually this procedure allow us in a multidisciplinary approach to, after revascularization, doing surgery of the foot and allow us to save the limbs and to save the feet in most of the patients. One of the limits of endovascular therapy is for sure the primary patency. It means that we are able to open this artery, but we are not able still today to maintain these vessels open. That's the reason why we need more devices, more therapeutic devices or therapeutic strategies. But on the other hand, drug-coated balloons are today, as I said before, one of the tools we have to fight with wrist stenosis. Another options are atherectomy. We have today very nice atherectomy devices from Boston, from CSI, and from many other companies, Philips, that allow us also to go below the knee and in some cases below the ankle, and it allows us to remove the plaque from inside of the vessels and finally use the drug-coated balloon to deploy the drug in the target lesion.
And at what point do you make the decision that endovascular is no longer enough, that a person may need to go into some sort of bypass procedure, such as a FEMPOP?
Well, my FEMPOP is still today a very good option in some population, some cohort of patients. It means patients with saphenous vein, no previous surgeries, and healthy tibial arteries. So from my perspective, I work in a diabetic foot center. My population, my patients are not this type of patients. Even if 50% of my population had FEMPOP occlusions or FEMPOP lesions and need the treatment also in the femoral and the popliteal arteries. In the other hand, when we talk about below the knee and below the ankle, there is no FEMPOP options. So what they need is a FEM distal bypasses. And in the cases like this, there is no option for surgery because you can do the anastomosis, the proximal anastomosis in the femoral arteries. But if you don't have any vessel in the foot, you cannot do the distal bypass anastomosis in an occluded target artery. So surgery is still a very good option today, but it's not available for all the patients.
So a few things that people can learn from this particular case is, one, if you have critical limb ischemia and your doctor says, well, without even trying, we kind of stopped the knee, your vessels are too small going down into your tibials or below the knee and into your foot, so time to bypass, time to amputate, nothing we can do. I think the moral of the story here and the lesson is that, wait a minute, find a doctor and ask the question, what is your skill set below the knee and into the foot? Some doctors here in the US will say that's extreme or that's radical, but there are doctors that we consider CLI fighters, critical limb ischemia fighters, CLI fighters, and you need to ask for those doctors. I can see you want to say something here.
Yeah, I absolutely agree with you, Kim. I mean, if the doctor is not able to perform the procedure, please send the patient to some colleagues. For the patients, those who can be involved with CLI, if someone talk about amputation, please ask a second opinion. And
CO2 is also very important. Don't think that you do not have any options. If you are sensitive to contrast, whether you have renal issues or it's just your body's chemistry, find a doctor, ask the question, do you use CO2? And are you proficient in looking at a fluoroscopy image and able to follow the CO2 clear into the foot. I think that's incredibly important, because even some doctors who have CO2 may not be proficient in following the CO2 into the foot.
Yeah, absolutely agree with you again, Kim. CO2 is another important tool to have today available in all the cath labs that allow us to treat any patient with allergic reaction to contrast medium, every patient with chronic renal failure, every patient with some other type of complications that cannot receive the liquids, and CO2 is a gas. So using it every day, I finished to use it every day in every patient, obtaining a very good result. So we can reduce saving money and giving to the patients a more efficient clinical evaluation with CO2 rather than with iodine.
And if you are someone that has a tendency to restenosis very quickly, basically your vessels are recoiling very quickly, it's really important to maybe ask your doctor, is there anything extra that you can do, low pressure balloon with maybe a DCB, a drug-coated balloon? Is that right for me? What is your opinion on that? And ask the doctor these questions, right?
Absolutely. We don't have too many alternatives, but we have some stents, drug-eluting stent, balloons, high-pressure balloons, drug-eluting balloons, atherectomy devices, laser, and some others, between others. So what I usually do is to go step by step, because if you implant stent today, you could have an occluded stent tomorrow. So the first time, if I achieve a good result with an angioplasty, maybe prefer to use a drug-coated balloon and avoid stent. I'm talking about fem-pop axis rather than below the knee. Below the knee, we try to do not implant stent because the results are not so funny till today, but we have even dedicated stent for below the knee. So go step by step, but know that there are other options. And talking about patency and endovascular approach, the good thing of the endovascular approach is that we can repeat it. I have patients that in the last 10 years perform maybe 6, 7 endovascular interventions, but they are not happy to be back, but they are happy to have the leg and the foot in the body.
That's fantastic. Any final thoughts, doctor, before we head out? No?
I'm sorry, I lose you. I lose the voice for 1 second.
Any final thoughts before we head out?
I think the most important message we can do for the population, for the patients, and for everyone that are following us is what I said before. If someone talked to you about amputation, ask for a second opinion.
Always.
And
always,
go in a dedicated places. Diabetic foot clinic, places with multidisciplinary team, with multidisciplinary approach, because honestly speaking, I'm dedicated for revascularization. I never take care about ulcers. I work in a team with another guys that take care about clinical situation, about surgical situation, and my job is only to open the arteries.
That's fantastic. I love that. And I have a new thing I'm going to be telling people: find a diabetic foot specialist, someone who has a specialty in working with patients and revascularizing the feet of people who have diabetes. Definitely a specialty. And if your doctor says it can't be done, find someone that can actually do it. So important. Thank you so much, Dr. Mariano Palena. We really, really appreciate you so much for taking the time to be with us today.